So no conflicts of interest. Why screen for lung cancer? Because it's the second most common malignancy in the United States in men and women. And as we all know, it's the most common cause of cancer death in the United States in men and women. You can see here that even in early stage lung cancer, our survival is not great. If we look at this over time, you can see that certainly we've not made the progress that other diseases have made. So it's a common malignancy, and our treatment is not very good. That's certainly a reason to screen for it. It's very difficult to prevent outside of stopping smoking, which seems to be very difficult for a large percentage of the population. So let's talk about screening. Screening is not just doing something to find a particular disease. A program should reduce cancer-related mortality and overall mortality in the screened group compared to the unscreened group. That's the science behind screening, right? Minimize unnecessary procedures, and as we'll talk a lot about, be relatively cost-effective. As of about 2007, most people would have answered this, that no technique used alone or in combination up until that point had proven to be of benefit in identifying people with lung cancer early enough to do the things that we just talked about. And this is a diagram showing that. You'll see in the lower right corner some progress began to be made with low-dose CT scanning in the late 90s, but those were mostly non-randomized trials. Why were all the previous trials not helpful? I think one reason is just the difference in chest X-ray and CT scan. And this is a chest X-ray and a CT scan of the same patient, and obviously a very different finding on the CT scan. Low-dose CT scan began to be of interest because you see, comparing a regular CAT scan and a low-dose CT scan, there's not a lot of difference in the quality there. You can certainly see the abnormality, but deliver much less radiation for the study. And so people began to look at CT detection of lung cancer. They had some very encouraging results, especially Dr. Henchy, who began to non-randomizingly look at these folks in significant numbers and began to find a high percentage of patients diagnosed with early-stage lung cancer. This is Dr. Henchy. She's a radiologist at Cornell. This became really a passion of hers and culminated in the international LCAP study where they looked at 31,000 patients in a single-arm observational study. They found 484 subjects with lung cancer, 85% of which were diagnosed in stage 1. And their estimated 10-year survival was 88%, even a little bit higher if they underwent resection in 1 month, obviously a selected group there. And so here you can see that in other studies they have shown that patients who are detected early and can undergo resection do have an increased survival. So again, the science of screening, these really should be evaluated in randomized control trials to minimize selection bias, lead time bias, length bias, and overdiagnosis. As Dr. Henchy's work was looked at, the next logical step was in a randomized trial. That was the National Lung Cancer Screening Trial, the results of which were published in the New England Journal of Medicine in 2011. This was a multi-center trial, 33 centers. They enrolled over 53,000 patients between 2002 and 2004. Their high-risk definition was age 55 to 74 with at least a 30-pack-year smoking history. They compared annual CT scans to chest X-ray for 2 years, and they followed these patients for 5 years, finishing in 2009. Anybody in the audience participate in that trial? A few people. Good. This is their results slide. You can see the positive results for CT scan significantly different than the positive results for chest X-ray. They were finding more abnormalities. This slide shows that they detected more lung cancers. They had a 20% reduction in lung cancer mortality and a 6% reduction in all-cause mortality. That 20% reduction in disease-specific mortality happens to be the same thing that you get from this machine. Anybody know what this machine is? It's a mammogram machine. So low-dose CT scan for lung cancer reduces the mortality of lung cancer by exactly the same amount as mammography does for breast cancer. And this just shows that we have a slightly higher false positive rate, but actually a much lower false biopsy rate. And the number of individuals needed to be screened to save one life is significantly less for low-dose CT scan for lung cancer than mammography. Here you can see one example on the left, a shift in stage at diagnosis from low-dose CT scanning for lung cancer. The stage 1 goes up, stage 2 and stage 3 go down in this particular example. And you can also see the cost effectiveness of low-dose CT scanning, $11,000 to $26,000 per life year saved, compared to cervical screening, breast, and colorectal, and we look pretty good compared to those. Radiation exposure, not a moot point in this case. A chest X-ray, which when I was a medical student I was taught, gives you about the same amount of radiation as flying cross-country. You see, compared to background, is about 10 days. Low-dose CT scan, about 6 months of background radiation, and a regular CT scan, about 2 years. So it's not negligible, but it's, I think most people would say, acceptable in a high-risk, well-defined population. And so what has all this meant for reimbursement? Well, the Preventative Health Task Force in 2013, as many of you know, gave this a B recommendation. That is the same recommendation as mammography has. The interesting thing with the Affordable Care Act, if you have a B recommendation or higher, private insurers are required to pay for that test. MedCAC, who determines Medicare eligibility, decided they would not, at this point, recommend low-dose CT scanning. So we have a situation where private insurers are required to pay for it and Medicare will not at this point. That's an ongoing battle with some of the folks in this room representing our specialty to try and get that changed. A lot of organizations are in support of this, but the one that you don't see, interestingly to me, is the American Association of Family Practice Physicians. When we started our program, the major pushback was actually from our primary care physicians who did not want to deal with it, did not want to take the time to explain it, offer it, and do the follow-up, and was somewhat disappointing to me, but I think we've gotten past that. But they as a specialty, are not on board with this. Our own screening program started in a single one of our hospitals in 2011. We screened about 367 patients. We expanded that to 5 of our hospitals, and our screening numbers have increased. We certainly have a lot of abnormal lung findings and other abnormal findings that we have to deal with, but to date we have had, I think, some success with this. We won't get into price point and all that kind of stuff, but it does affect this, and certainly this is something that you do need to market, at least initially, and market carefully, because you do just need to screen the high-risk patients. These are the 2015 NCCN guidelines for lung cancer screening. We have adopted their guidelines as we've gone through the screening program, and this has evolved, and we're excited about the addition of another high-risk population, the age 50 or up with 20-pack year smoking history, with one other risk factor. When we began, we used criteria similar to MD Anderson, which were a little more liberal. We then went to the more strict criteria and are now able to loosen that up a little. You will notice, and there's been no movement on this, that secondhand smoke exposure is not an identified risk factor, so that does not count. I would just encourage you, if you're going to start a screening program, do use some guidelines. I think it's helpful for your program. It's certainly the right thing to do for the patients. There's a technical component to these programs, and you have to make sure you're actually doing a low-dose CT scan and that you have the right software and the right equipment. You have to partner with your radiologists. They have to be aware of this kind of data and use it correctly so that you're actually doing the right test for the patient. And then lastly, the NCCN has put in print some of the risk-benefit discussion points that you want to talk to patients about, and this has certainly been beneficial for our primary care physicians to get this in their hands. They do feel more comfortable now. They are beginning to offer it to their patients instead of patients having to do it on their own. So in conclusion for my part of the talk, and Dr. Howington will go into more of how to follow the positive results, but lung cancer remains the most common cause for cancer death in the United States in men and women. We all know it's more often diagnosed in advanced stage, and there is a more effective treatment the earlier it's diagnosed. The best methods of early detection so far identified is low-dose CT screening, which decreases disease-specific and overall mortality in the screened population, and compared to other screening tests that we all take for granted, is cost-effective. Thank you.